Three and a half years ago, I made the biggest decision in my life. I work for a global pharmaceutical company as a business unit manager for world top-selling drug named Humira. But my decision was to leave the company and become a board member of a very early stage biotech developing cell therapy products for heart failure. So at that time, my company, Heartseed, was a baby stage. But as a COO, I've raised $75 million and announced a licensing deal with Novo Nordisk, the world-leading pharmaceutical companies, with milestone payment totaling up to $600 US. The decision I made is that I wanted to do something totally new, create a new treatment modality rather than thinking about how to differentiate our products with competitors. So today, I'd like to talk about our development journey of curative therapy. So everyone here thinks that curative therapy is much better than symptomatic improvement. So the definition of curative therapy is that curative therapy is a time-limited, desirably one-time treatment that removes the symptoms of the disease through a permanent correction of the underlying condition. So not just manage symptoms or disease progression, but this has to address the root cause of that's the curative therapy. So what can you think of the example of curative therapy? There are several types. For example, raw molecules or pills. Interferon-free HCV drug is one of the things that I can easily think of. Its efficacy is very excellent, and it totally eliminates the virus in an 8-week or even shorter period. The ultimate side, the organ transplant, obviously, replaces the damaged organ with healthy ones. So it's also a curative therapy. In between, there is an emerging treatment modality named cell and gene therapy. So everyone knows Kymriah, CAR-T, is very effective. And also, gene therapy can be a curative therapy, especially if the target is a single gene mutation. The another emerging one is the stem cell-derived functional cells that replace the damaged tissue. So this can be the alternative of organ transplant, which is in significant shortage of donors. So there are challenges in all modality. So for raw molecules, obviously it's becoming more and more difficult to target the identify the right target. Organ transplant and also the cell and gene therapy, there is issues such as immune rejection, how to deliver effectively, and manufacturing. So what are the stem cells? Are you familiar with? The stem cells has a unique capability to self-regenerate and also produce various types of cells. So one characteristic is the unlimited proliferation, meaning these cells divide eternally. The another one is undifferentiated, meaning these cells can become any type of cells, such as heart cells, liver cells, neurons, etc. So there are two types of these cells, pluripotent stem cells. One is ES cells, and the other is iPS cells. So ES cells, shown on the left, is usually produced from inner mast cell of a blastocyte. So it starts from the fertilized egg, so there is an S-curve issue. But in iPS cells, which is induced pluripotent stem cells, this cell can be manufactured from everyone, from your cell, your skin cell, or your blood cell, by transforming Yamanaka factors. You can manufacture your own iPS cells. At this moment, you have to pay $1 million to manufacture your own iPS cell, but desirably, the cost will dramatically decrease in the near future. So application of iPS cells, Professor Yamanaka won the Nobel Prize because its usefulness in drug screening, because you can manufacture iPS cells from patients, and these cells once after differentiation into cardiomyocytes or other type of cells, these cells can be very useful for drug screening, mechanism study, etc. But on the right, here is what I will talk about, regenerative medicine. So this one, iPS cells are differentiated into other type of cells, and these cells are used as a drug. So living cells are the drugs. So this is the stem cell therapy. And we are targeting a heart disease because heart disease is by far the leading cause of death worldwide, second to cancers or other diseases. And this is the video of heart failure. So as you can see, the heart function, pumping function becomes very weak in heart failure patients compared with healthy individuals. So hearts cannot pump out enough blood to meet the oxygen needs of the body. And patients feel shortness of breath, fatigue, and sometimes in pain, leading to hospitalization and sometimes death. And over 65 million patients worldwide are suffering from heart failure, and the number is on the rise. There are several treatments, but these are all symptomatic treatment other than heart transplant. So the survival of heart failure is very severe compared with some other type of cancers. And what's different with cancer is that the cancer treatment costs a lot of money at the end stage of the life. But heart failure, since it repeats the disease worsening for several times and multiple number of hospitalizations are needed, its cost burden is also significant. So there are a lot of attempts to develop a cell therapy for heart failure. But previous approach is shown on the left. The cells used was not the cardiomyocytes, not the heart muscle cells, not the beating heart muscle cells, but something other type of cells, progenitor cells, mesenchymal stem cells, etc. These cells obviously do not beat. So these cells' efficacy is delivered by paracrine effects, meaning these cells release some cytokines or growth factors that heal the damaged heart. They don't replace the damaged tissue. So efficacy was modest at most, but there are a lot of clinical trials, all are in failure. No approved drugs in FDA. So what's promising approach is to transplant functional cardiomyocytes itself. In this case, these cells attached to patient's heart engraft with patient's heart through electronical coupling, so beat in synchrony with patient's heart to supplement the pumping function by generating direct contractile force. This is called remuscularization. In this case, efficacy is much better. The response rate is 100%, like implanting the device, and the improvement is robust. But there are a lot of challenges to apply this in clinical settings. So I'm going to show you the video of how remuscularization occurs into the damaged heart, transplanted cells, engraft, and grow, and stay there for eternally, and generate a direct contractile force to improve the cardiac function and desirable prognosis of the disease. So there are a lot of challenges. One is purification. What does it mean? If we differentiate some target cells from iPS cells, we cannot make 100% cardiomyocytes, meaning other cells, residual pluripotent stem cells or non-target cells remain. So if we transplant these cells together, there is a tragedy. Tumor will occur, named teratoma. So to avoid this tumor formation, we have to purify the transplanted cells. So our strategy is to just change the cell culture medium. In these states, cells are cultured in a plate. But by changing just cell culture medium, only the red cells, cardiomyocytes, can survive, but other cells are dying. We can obtain a large amount of purified cardiomyocytes. So this is our strategy, and it was actually possible. Left-hand side shows a video of heart muscle cells before purification. As you can see, there is a beating cells like a fiber state. These are cardiomyocytes, but in between these fibers, there are non-cardiomyocytes. But if after purification, you can see all the beating cells are cardiomyocytes, but other cells are dying. This was achieved by just changing cell culture medium named metabolic selection. Glucose and glutamine are depleted, but lactate is added instead. Why? Because both iPS cells and cardiomyocytes, and actually all type of cells, use glucose as a main energy source. So without glucose, all cells will die because they cannot generate nucleic acids or ATPs that are necessary for the cells to survive. But if we add lactate instead, stem cells cannot use lactate, but cardiomyocytes can interestingly use lactate as an energy source, and in their TCA cycle, they can generate ATP using lactate. And we also deplete glutamine, because glutamine is one of the amino acids that are used as an energy source the most. And if we deplete glutamine in addition to glucose, the iPS cell will die quickly. So basically, cardiomyocytes and non-cardiomyocytes and the residual iPS cells, metabolic pathways totally different. Only cardiomyocytes can use lactate as an energy source. So we can selectively obtain cardiomyocytes in 100% purity by this simple method. The next challenge is the engraftment of the cells. This is a traditional approach transplanting a single cell into heart muscle. The challenge was that engraftment rate. It was very low, only 3% by single cell injection, because a single cell is very fragile and the viability is very low. So how to solve this? We form spheroids or aggregates of cardiomyocytes. By forming this microtissue, the cardiomyocytes release growth factors and cytokines each other, and they become much stronger microtissue. By doing so, engraftment rate was dramatically improved, more than 20 times compared with single cell injection. So engraftment was solved by this kind of methods. So this video is showing the cardiomyocytes transplanted into mice skin. And 1 year after transplantation, as you can see in the center of the video, you can see beating cardiomyocytes even after 1 year. So it is very amazing. And new blood cells are formed to supply nutrients to cardiomyocytes. So considering the lifespan of the mice, 1 year observation is the maximum. But we really believe that these transplanted cardiomyocytes will keep functioning eternally as your cardiomyocytes do. And actually, these transplanted cardiomyocytes become bigger and bigger after transplantation. Compared with 3-week and 8-week, the single cell size becomes bigger and generate a stronger force. So what is the animal studies? So there is one concern that these transplanted cells cause irregular heartbeats or arrhythmia. And this is caused by the mechanism called the graft automaticity, which means that transplanted cells generate an irregular pulse. And there are several types of arrhythmias, PVC and non-SVT. These are not much an issue, but SVT, shown on the right bottom, is the issue. Because this cell, if this state lasts, you cannot pump out enough blood, and sometimes leading to very severe condition. We transplant our human iPS cell-derived cardiomyocytes into monkey heart. And interestingly, these cells engraft with monkey heart without any inflammation. It's quite amazing. Human tissue engrafts with monkey heart. And how about the arrhythmias? The arrhythmia was very limited. Only 1 in 5 monkeys showed arrhythmia, but it was only 9 minutes per day. Previous reports suggest that, by other groups, said that SVT, arrhythmia, occurs more than 10 hours per day or almost all the day. So why this is so good in terms of safety? Because we can create ventricular specific cardiomyocytes, high purity, and also we are good in terms of engraftment rate, very few death cells. And also we developed a dedicated device to minimize the damage of the tissue. So all these things make our therapy into clinical phase. And also efficacy, I forgot to mention about the efficacy of monkeys. So of course our efficacy was great and 100% response rate was shown. And these cells, interestingly, transplanted into monkey heart shows synchronous beating. This shows that beating is shown in green flashes. So 3 separate sites, transplanted cardiomyocytes, beat in the same timing, meaning these cells connect with the patient's heart. And that's why these cells, although separated, keep beating in the same timing. So we just initiated a human trial named the RAPID study in Japan. 10 patients will be enrolled and observed for a year. So we are very confident that our therapy will work in monkey and also of course pig and rats. But what we have to confirm in human is immune rejection. So immune rejection occurs by the attack of T cells and NK cells. So there are 2 types of T cells, CD8 positive and CD4 positive cells. And there are a lot of attempts to how to avoid this immune rejection. One way, CD8 recognizes HLA1, HLA class 1, and CD4 recognizes HLA class 2. So one approach is that by gene editing, remove this cell expression. Because if we, how can I say, knock out HLA1 or HLA2, then T cells won't recognize the transplanted graft. But immune system is very complex. So if we knock out HLA class 1 or HLA class 2, then NK cells recognize something strange. So NK cells will attack these cells. So this is very difficult, and there are a lot of efforts going on globally. So another approach is to HLA matching. So HLA is like a blood type. So if the HLA is the same, the immune rejection is much smaller because HLA is the main cause of the immune rejection. So there are some, among us, maybe there are someone who have a HLA haplotype homo, meaning your father and mother have the same type of HLA. So this person is called the HLA haplotype homo. By using these types of cells, about 30% of patients, 30% of people in Japan can be the HLA matched, meaning the HLA type is the same, so immune rejection is very limited. So this rate, of course, differs by country. Japan is a relatively homogeneous country, so 30% is quite high. But our, this is one way of approach. So ultimate approach is use your own cells, use patient's own cells, meaning autologous therapy. Blood sampling and reprogramming these cells and make iPS cells, and then differentiate these cells into heart cells or liver cells, your target cells. So this is called autologous therapy. This is ideal, but the challenge is obviously the cost and inefficiency and quality variance. What does it mean in inefficiency? So iPS cell is great, but making iPS cell is still very difficult. The efficiency of successfully making iPS cell is very low. OSK is a reprogramming factors. These cells, by transplanting these cells, we can create iPS cells, but the efficiency is very low. But by adding H1FOO, the efficiency increased 8 times. And also, variation means if we try to differentiate iPS cells into target cells, in our case cardiomyocytes, the differentiation efficiency without H1FOO is about 70%, and there is a wide variance bars. But by adding H1FOO, the differentiation rate improved to 90%, and the variance becomes much lower. So H1FOO can be a key therapy for the autologous iPS cell therapy. So what is H1FOO? As you know, DNA is, how can I say, strangled like this shown, and is basically wrapped around the histone. And there are two states, urochromatin and heterochromatin. In urochromatin, where the DNA's wrapping is loosened, it's easy to read this DNA, and the protein expression is easy. But in heterochromatin state, the DNA expression is suppressed. What does H1FOO do is that H1FOO loosens the wrapping of a DNA. And so this will contribute to the efficient reprogramming factors because OSK, OCT-SOX-KRF, works much better with transplanting H1FOO. So lastly, delivery. So first, we are transplanting our cells in open chest surgery. So there is invasiveness. This is invasive therapy, obviously. Although we manufactured our original needles, that there are side holes, and the tip of the needle is round, so this needle doesn't damage the tissue. So bleeding is very limited. But we also are developing or considering the catheter injection. This is much easier for patients without surgery. So our roadmap is here. We start with HLA matched one in Japan, but we want to expand into HLA unmatched patients. But these patients have to use immunosuppressants, which is expensive and side effects are concerned. So next step is to use HLA knocked out cells. And ultimately, we want to deliver our therapy with your patient's own iPS cells, autologous therapy. And as for y-axis route of administration, we start with open chest surgery and then move to transendocardial injection. So this is the development journey of curative therapy for heart failure using iPS cells. What we are thinking is that we want to expand this kind of technology into other therapeutic areas, other type of disease, because the basic platform technology is the same. iPS cell manufacturing, purification, engraftment, cell delivery, and also clinical, regulatory, and manufacturing expertise. We can utilize these experiences into other fields. So sometime near future, that stem cell-based therapy can be the curative therapy that everyone can receive at any time, anywhere. That's our dream. Thank you very much for your attention. And I'm happy to take any questions you may have.
Hi. Hello. Thank you for the wonderful session. I'm Suman Chinta. I'm representing Zybian Digital here. I have gone through the entire presentation. It is really wonderful. The only question I have is, when compared to the CAR-T gene therapy, cell and gene therapy, you are collecting the blood sample from the patient, and you are doing the leukapheresis, FRSS, and then you are actually doing the gene editing on the cells that you have taken, and then you are producing the cells in mass, and then re-injecting into the patient. So that way you are making sure that the body rejection doesn't happen, the immunorejection doesn't happen. Whereas in this case, what I observe is you are collecting the cardiomyocytes from the heart, so which has lost its reflexology, right? So you are collecting those cells, and you are doing the same process like the CAR-T, the immunotherapy one, and you are again bulk producing the cells and re-injecting into the heart, where they are actually regaining the reflexology part, right? Did I understood you right?
Not 100% correct. So in our case, we can start with healthy donor iPS cells or patient's own iPS cells.
Okay.
So this can be manufactured from a drop of blood. So this is the easiest way to as a starting material.
So basically, you're exploring the pluripotency and totipotency nature of the cells. So it can be from the same patient or it can be from a donor, right? This leads to my second question. Like the core cause is not solved, right? When you look at the heart attacks and all, it is because of the coagulation of the vessels, the blood vessels. Because of that, the heart attacks usually come. And if you have this condition for so long, then the reflexology of your heart cells may be going away. So this is a treatment for that, not for the heart attack, right? It is for the regeneration of your heart. Did I understand it right?
So yes, in broader terms, it is a regeneration of the heart. But regeneration means two terms. One is your damaged scar tissue become a normal one, revert back to normal state. In our case, what we are thinking is supplementing artificial heart muscle cells, replacing instead of the damaging heart. So because the heart muscle cells cannot regenerate after we become adult, the only curative way is to add or supplement artificial cardiomyocytes into the damaged patient's heart.
So your process would eliminate the process of transplantation or xenotransplantation from other donors, and replacing, instead of that, you are making the heart of the same patient like before or much better by injecting these processed cells which are genetically edited and re-injecting them so that with the same heart would perform normal, right?
Sorry, I'm not fully understand your question, but
if the heart fails, right? So the cure for that is either you would do the transplantation or you would do the xenotransplantation, which is basically the cross transplantation. So instead of doing that, your method would, like for the same patient with the same heart, you are trying to inject this cardiomyocytes and regenerating or regenuating the same patient's heart, right? That is what you are doing.
Yes. So I think someone from this room saw the news that in the US, the patients with advanced heart failure stage received a xenotransplantation of the heart, meaning pig's heart. Pig's heart was genetically modified to suppress the immune rejection and transplanted into patient's heart early this year. And unfortunately, the patient died, but the patient lived for 2 months with pig's heart, which is amazing. So there is a totally different approach, xenotransplantation, meaning that different animals' organ will be transplanted into human. That's a very innovative and exciting approach, but our therapy is more, how can I say, can be a common treatment, everyone's treatment, because your patient's own cells can be used. So if you stock your iPS cells, and then you can, as you get older and you become sick for example, heart or liver, from your iPS cells, liver cells or heart cells can be manufactured and transplanted to your body when it's necessary. That's the ultimate goal of the future personalized treatment.
Oh, thank you very much for answering all my questions. Thanks a lot.
Thank you. So this is just a build up on the previous question, which is, I was just going to ask you a bit more about, so I'm Samir, I've worked in heart failure pathway a lot, and one of the things is that the patient has got multiple morbidities, multiple other dysfunctions happening in the body, right? On an average 3 for heart failure. And when heart fails, I think this is the build up to the previous question, when the heart fails, then you really want to address the heart's failure and not any other kind of management of the tissue around. So which type of patient is going to benefit from your therapy the most? Is it going to be, and let me just give you a vignette, is it going to be a 40-year-old person who's got hypertension and heart failure and loses the pumping of the heart, or atrial fibrosis, or a 75, 80-year-old person who's absolute candidate for heart transplantation?
Thanks so much for your question. So your question is, what kind of patients are ideal target for this kind of therapy? And I think that's a very important question. So so compared with oncology, for example, there are a lot of subsegmentation in, for example, colorectal cancer or lung cancer. Basically, we can target all heart failure patients with reduced ejection fraction, meaning their systolic pumping function becomes weaker due to the loss or damage of cardiomyocytes, heart muscle cells. This happens by, for example, heart attack, myocardial infarction, or cardiomyopathy. So these type of patients with a reduced systolic function is our primary target. And about half of the patients of the heart failure is in this category.
Excuse me. So a very insightful presentation. Thank you so much for that. Just another offshoot is that also prior to heart failure, or sometimes accompanying heart failure, we see that there are instances of the valves going, valvular dysfunction. So is your technology also capable of, right now we're either using prosthetic valves or bovine valves. Would your technology, could it also be leveraged for eventually manufacturing healthy valves, which can then via catheterization inserted into the heart of the individual?
Sorry, quite difficult to catch your question. Maybe you're wearing mask. Maybe.
Basically, what I mean is that many times there's also valvular dysfunction. So with your technology, would it be possible to, instead of using a prosthetic valve or a bovine valve, a pig valve, would it be possible to have an external, re-engineering a valve and then via catheterization inserted back into the individual?
So your question is about if we can stop additional drug therapy?
Basically, would we be able to use this for valves too? Right now, it's just primarily for heart failure, right? Mm-hmm. To regenerate the tissue. Mm-hmm. But many times, also if the valves are friable and they need to be replaced, could we see something like this going forward in the valvular technology?
So basically, we can intervene at any timing of the patient disease course. Considering the cost effectiveness or payer burden, we are thinking about targeting severe patients, but this can be at any type of stage. Just after the heart attack is also possible.
Okay, last question.
Hello. A wonderful, insightful session. I just have one question regarding most stem cell therapies. That how do you take in consideration of the neoplastic and the carcinogenic tendencies of most stem cell therapy? Thank you.
Sorry, maybe I will follow up you later because I couldn't catch your questions correctly. So, thank you.
Thank you.
Yes, let's do that. Thank you so much. That was...